Neonatal pneumonia is a significant cause of morbidity and mortality in the newborn period. Although it affects fewer than 1% of term infants, it occurs in up to 10% of extremely low birth weight infants who require mechanical ventilation. In this population, pneumonia accounts for approximately 30% of deaths, highlighting the critical need for early recognition and intervention. Presentation is often nonspecific, with respiratory distress being the primary manifestation. Because these signs overlap with other common neonatal conditions, such as respiratory distress syndrome, meconium aspiration syndrome, and transient tachypnea of the newborn, careful evaluation is essential to establish the correct diagnosis. Timely identification guides targeted therapy and supportive care, which are key to reducing complications and improving outcomes. Neonatal pneumonia is classified by when symptoms appear because timing directly informs the likely pathogenesis and causative organisms. Early-onset pneumonia, presenting within the first 72 hours of life, is usually acquired during labor or delivery. The fetus may aspirate infected amniotic fluid, which contains bacteria from the maternal genital tract, or infection may occur via transplacental transmission. These mechanisms explain why early-onset cases are often associated with maternal infection or chorioamnionitis. Late-onset pneumonia, occurring after 72 hours, can result from community exposure or hospital-acquired infection. In the hospital setting, prolonged use of endotracheal tubes, central lines, or mechanical ventilation increases colonization and invasion by bacteria. Late-onset cases are also influenced by underlying lung disease, such as bronchopulmonary dysplasia or neurologic impairment that increases aspiration risk. Timing is therefore critical because it shapes both the risk assessment and empiric therapy. Early-onset pneumonia tends to involve group B Streptococcus or Escherichia coli, while late-onset cases include a broader spectrum, including coagulase-negative Staphylococci, Pseudomonas, and other nosocomial organisms. Recognizing this temporal pattern allows clinicians to anticipate severity, tailor monitoring, and optimize antibiotic coverage. Early-onset neonatal pneumonia is primarily influenced by maternal and perinatal conditions that increase the likelihood of vertical bacterial transmission. Chorioamnionitis, or intraamniotic infection, introduces pathogens into the amniotic fluid, which the fetus can aspirate either during labor or immediately after birth, establishing the initial nidus of infection in the lungs. The duration of membrane rupture directly correlates with bacterial exposure, as prolonged rupture allows ascending organisms from the maternal genital tract to colonize the amniotic fluid. Maternal colonization with group B Streptococcus further elevates risk, particularly when combined with maternal fever, which signals systemic inflammation and likely higher bacterial load. These factors collectively enhance the probability of early pulmonary infection. Prematurity and low birth weight are critical neonatal risk factors. Preterm lungs are structurally immature, with decreased alveolarization and reduced surfactant, which impairs innate defenses and mucociliary clearance. Low birth weight is often a marker of growth restriction or systemic vulnerability, amplifying susceptibility to infection and increasing the likelihood of severe disease. Recognizing these early-onset risk factors is essential for anticipating neonatal pneumonia, guiding empiric antibiotic therapy immediately after birth, and prioritizing monitoring for respiratory compromise. Bacterial pneumonia in neonates varies depending on the timing of onset, which influences both the type of pathogens and the pathophysiology of lung injury. Early-onset pneumonia, occurring within the first 72 hours, is most often caused by group B Streptococcus and Escherichia coli. These organisms are typically acquired intrapartum, either through aspiration of infected amniotic fluid or vertical transmission across the placenta. GBS can induce a rapid systemic inflammatory response, while EColi may produce endotoxins that exacerbate pulmonary and systemic inflammation. Late-onset bacterial pneumonia, developing after 72 hours, often includes coagulase-negative Staphylococci, Pseudomonas, Serratia, Citrobacter, as well as GBS and E. coli. These pathogens are frequently hospital-acquired and associated with invasive devices such as endotracheal tubes and central lines. Late-onset organisms can produce biofilms on catheters, persist in the airway, and contribute to prolonged infection, increasing the risk of systemic sepsis and ventilator-associated complications. Certain bacteria have characteristic pulmonary effects. For example, Staphylococcus aureus and Klebsiella can cause tissue necrosis, abscess formation, and empyema. Chlamydia trachomatis can lead to a febrile pneumonia beyond 2 weeks of age. Understanding the pathogen profile allows clinicians to tailor empiric antibiotic therapy, anticipate potential complications, and monitor for systemic involvement. Viral and fungal pathogens contribute significantly to neonatal pneumonia, particularly in preterm or immunocompromised infants. Viruses such as herpes simplex virus, HSV, cytomegalovirus, CMV, enterovirus, respiratory syncytial virus, RSV, influenza, adenovirus, and SARS-CoV-2 can cause primary pulmonary infection or exacerbate bacterial pneumonia. HSV can result in disseminated disease with multi-organ involvement, while RSV primarily affects the lower respiratory tract, leading to bronchiolitis and alveolar inflammation. Fungal pneumonia is most commonly caused by Candida species, especially in extremely low birth weight infants or those receiving broad-spectrum antibiotics or corticosteroids. Candida can invade the lungs and bloodstream, leading to systemic candidiasis and high morbidity. Aspergillus infections are rare, but may occur in outbreaks, particularly during hospital construction, and can produce necrotizing pneumonia. These pathogens often cause a diffuse inflammatory response, damaging alveolar epithelium, increasing capillary permeability, and resulting in impaired gas exchange. Viral and fungal pneumonia may present indistinguishably from bacterial pneumonia, making microbiologic evaluation, PCR, culture, or antigen detection essential for diagnosis and guiding therapy. Neonatal pneumonia presents differently depending on timing. Early-onset pneumonia within the first 72 hours results from intrapartum or transplacental infection. Infants show respiratory distress immediately or soon after birth, including tachypnea, grunting, and apnea due to alveolar inflammation and impaired gas exchange. Temperature instability may present as fever or hypothermia, reflecting systemic inflammatory response. Tachycardia, poor perfusion, and possible septic shock indicate early cardiovascular compromise, while lethargy, metabolic acidosis, and abdominal distension reflect multi-organ stress. Late-onset pneumonia occurring after 72 hours often presents as nonspecific systemic illness in hospitalized or community infants. Respiratory signs include apnea, tachypnea, and general respiratory distress. Feeding intolerance, vomiting, and abdominal distension frequently accompany the illness. Jaundice or a sepsis-like picture may be present, particularly in preterm infants. Ventilated infants may demonstrate increased oxygen and ventilator requirements, and purulent secretions reflecting infection superimposed on existing lung compromise. Evaluation of neonatal pneumonia requires a full sepsis workup because systemic infection can progress rapidly in neonates and presentation is often nonspecific. Blood cultures and complete blood count are essential to identify bacterial pathogens and assess the inflammatory response. Inflammatory markers such as C-reactive protein or procalcitonin may support the diagnosis but should be interpreted in context. If there is concern for meningitis, cerebrospinal fluid culture should be obtained. In intubated infants, tracheal aspirate cultures help distinguish true pulmonary infection from colonization, guiding antibiotic therapy. For suspected viral pathogens such as herpes simplex virus, cytomegalovirus, or respiratory syncytial virus, PCR or viral culture is indicated. Pleural fluid culture may be performed if an effusion is sampled, particularly in cases of empyema. This comprehensive evaluation identifies the causative organism, determines severity, and directs targeted therapy, which is critical for reducing morbidity and mortality in neonatal pneumonia. Chest radiography is a cornerstone in diagnosing neonatal pneumonia. Typical findings include bilateral pulmonary opacities or focal infiltrates with air bronchograms, reflecting alveolar consolidation and interstitial inflammation. In some cases, the radiograph may show diffuse hazy opacities, which can mimic respiratory distress syndrome, or coarse patchy opacities, resembling meconium aspiration syndrome. Pleural effusions are more common in pneumonia than in RDS or MAS, signaling significant inflammatory exudate or parapneumonic fluid. Early in the disease, radiographs may be deceptively normal, so correlation with clinical status is essential. Radiographic evaluation helps distinguish pneumonia from other neonatal respiratory disorders, guide severity assessment, and monitor response to therapy. Lung ultrasound can be a sensitive tool for evaluating neonatal pneumonia, especially when radiation exposure is a concern. Hypoechoic areas of consolidation with irregular margins indicate alveolar filling and inflammatory edema. Within these consolidated areas, dynamic air bronchograms may be observed, representing trapped air in bronchi surrounded by fluid-filled alveoli. Ultrasound is particularly helpful in ventilated infants, as it allows real-time assessment of lung aeration and consolidation without repeated radiation. When performed by experienced clinicians, sensitivity can be high, although it is not yet routine in all centers. Lung ultrasound also aids in differentiating pneumonia from TTN or RDS, as these conditions typically show more uniform lung involvement without focal consolidations or air bronchograms. Neonatal pneumonia must be distinguished from other causes of respiratory distress, as management differs significantly. Transient tachypnea of the newborn usually resolves rapidly and lacks systemic illness or significant consolidation on imaging. Respiratory distress syndrome primarily affects preterm infants and is characterized by low lung volumes, diffuse ground glass opacities, and absence of air bronchograms in the early phase. Meconium aspiration syndrome presents with coarse breath sounds, hyperinflation, and a history of meconium-stained amniotic fluid. Pneumothorax can mimic sudden respiratory deterioration and is identified by transillumination or absence of lung markings on radiograph. Congenital anomalies, such as congenital diaphragmatic hernia or congenital pulmonary airway malformations, may present with asymmetric aeration or mediastinal shift. Cyanotic congenital heart disease can produce refractory hypoxemia, distinguishing it from infectious etiologies. Careful evaluation of history, physical findings, and imaging allows differentiation between these conditions, ensuring timely and appropriate treatment. Supportive care in neonatal pneumonia focuses on stabilizing respiratory function, maintaining homeostasis, and supporting organ perfusion. Infants are admitted to the NICU for close monitoring of oxygenation, respiratory effort, and hemodynamics. Oxygen therapy is titrated to maintain adequate tissue oxygen delivery, and mechanical ventilation is initiated if respiratory distress or hypoxemia persists. A neutral thermal environment minimizes metabolic demand, while glucose monitoring and fluid management ensure energy supply and prevent hypoglycemia or dehydration. Critically ill infants may require vasopressors to support systemic blood pressure and maintain perfusion. Handling is kept to a minimum to avoid increases in oxygen consumption and pulmonary vascular resistance. These interventions stabilize the infant while definitive therapy is determined, allowing time for microbiologic diagnosis and targeted treatment. Early-onset neonatal pneumonia is treated empirically with Ampicillin plus Gentamicin, which provides coverage for group B Streptococcus, Listeria monocytogenes, and common gram-negative organisms such as Escherichia coli. This combination targets both the most likely pathogens acquired intrapartum and those associated with maternal infection. Third-generation cephalosporins, such as cefotaxime, are generally avoided initially due to increased risk of resistance and higher mortality in neonates compared with Gentamicin-based regimens. Once culture results and susceptibility data are available, antibiotic therapy is adjusted to target the identified pathogen, ensuring effective eradication while minimizing toxicity. Empiric coverage is critical in the first hours of life because early-onset pneumonia can progress rapidly to septic shock, multi-organ involvement, and severe respiratory compromise. Late-onset neonatal pneumonia occurring after 72 hours of life often involves hospital-acquired or community pathogens. Empiric therapy typically includes ampicillin or vancomycin combined with an aminoglycoside such as gentamicin or an extended-spectrum cephalosporin like cefotaxime, ceftazidime, or cefepime. Vancomycin is indicated in units with a high prevalence of methicillin-resistant Staphylococcus aureus or for infants with hospital-acquired infections. Antibiotic regimens are modified once culture and susceptibility results are available, allowing for targeted therapy and minimizing unnecessary broad-spectrum exposure. Treatment duration is usually 7 to 10 days for uncomplicated cases, but longer courses may be necessary for severe infection, abscess formation, or coexisting complications. The choice and timing of antibiotics are guided by pathogen likelihood, site of infection, and clinical severity, balancing efficacy with the risk of toxicity and resistance. Definitive therapy for neonatal pneumonia is tailored to the identified pathogen and its antimicrobial susceptibility. For Group B Streptococcus, treatment typically involves penicillin or ampicillin, which effectively eradicates the organism from the bloodstream and lungs. Escherichia coli is treated with ampicillin if sensitive, or alternatively, a third-generation cephalosporin or aminoglycoside based on susceptibility. Klebsiella, Enterobacter, and Serratia infections require therapy guided by culture results, and in some cases may necessitate a carbapenem for resistant strains. Staphylococcus aureus is managed with nafcillin for methicillin-sensitive strains or vancomycin for methicillin-resistant strains. Chlamydia trachomatis pneumonia is treated with oral azithromycin. Selecting the appropriate definitive therapy ensures effective pathogen clearance, minimizes the risk of resistance, and addresses the underlying cause of lung inflammation, improving outcomes in both term and preterm infants. The course and prognosis of neonatal pneumonia depend heavily on gestational age, birth weight, pathogen, and severity of illness. Term infants in resource-rich settings often recover fully with appropriate supportive care and targeted antibiotic therapy. In preterm or extremely low birth weight infants, pneumonia is associated with higher morbidity and mortality, reaching up to 30% in some cohorts. Complications may include prolonged mechanical ventilation, bronchopulmonary dysplasia, systemic sepsis, and multi-organ dysfunction. Long-term sequelae in high-risk infants can include chronic lung disease, recurrent infections, and neurodevelopmental impairment, particularly when early hypoxemia, sepsis, or inflammatory injury occurs. Monitoring and follow-up are crucial for early identification and management of these complications. Neonatal pneumonia is a major cause of morbidity and mortality, particularly in preterm and extremely low birth weight infants. It is classified as early onset, within 72 hours of life, or late onset, after 72 hours, which guides the likely pathogens and empiric therapy. Common causative organisms include Group B Streptococcus, Escherichia coli, Klebsiella, Staphylococcus aureus, Pseudomonas, and Chlamydia, with viral and fungal pathogens contributing in specific populations. Diagnosis requires full sepsis evaluation, imaging, and culture studies, combined with careful interpretation of clinical signs, which may be nonspecific. Management integrates supportive care, empiric antibiotics, and targeted therapy once cultures are available. Severe cases may require ventilatory support or treatment for septic shock. Outcomes are generally favorable in term infants with timely intervention, but preterm or ELBW infants have higher mortality and are at risk for chronic lung disease, recurrent infections, and neurodevelopmental impairment.